panelists tonight are just a wonderful group of people, and we're going to first hear from Gunter Bischoff. Gunter Bischoff is a native of Austria and has taught at UNO for more than 20 years. He's the Marshall Plan Professor of History and Director of Center Austria at the University of New Orleans. He was appointed a University Research Professor in June of 2011. He served as a visiting professor at the University of Munich, Innsbruck, Salzburg, Vienna, the Wirtschaftsuniversität of Vienna, and the post-Katrina visiting professor at LSU in the fall of 2005. You'd think I'd be able to pronounce that. My parents were from Germany, but I must say that my German is really a little rusty. He's published books on, the author of the books on Austria in the First Cold War, 1945-55, The Leverage of the Weak in 1999, co-editor of Contemporary Austrian Studies and the Cold War in Central Europe, among them with Barbara Steitz-Marx and Stefan Kardner, the Vienna Summit of 1991. And with Stephen Ambrose, Facts Against Falsehood, Eisenhower and the German POWs, an Eisenhower Century Assessment, and with Saki Dockeral, Cold War Respite, the Geneva Summit of 1955. He also serves as a presidential counselor at the National World War II Museum in New Orleans. A great intellect, an individual who has truly studied the issues that have come out of the Second World War. And he's going to start off the conversation by putting the exhibit in historical context. To his right is Dr. Samir Eldar, who's a professor and chair of pediatrics at Tulane School of Medicine, a world-renowned pediatric nephrologist with a large research operation in kidney diseases related to children. In addition to be a basic science researcher, Samir has a passion for caring for the underserved, a passion about global medicine, our responsibility in developing countries. And he himself was born and raised in Syria and watches that country spiral into a civil war and is going through great personal pain watching this and understands the problems confronting civilian populations in a war zone probably better than any of us can imagine. To his right is Dr. Karen DeSalvo, a figure that everybody in the city knows, is the Commissioner of Health for the city of New Orleans, professor of medicine at Tulane, and has devoted her career to improving healthcare in our city and has done an incredible job. Under her, the healthcare environment post-Katrina was truly revolutionized, modernized, because of the work that she did both with the state and with the federal government in bringing about the introduction of community health centers across the city. She now works with Mayor Landrieu and is really taking a very active role in further reforms in the city. To her right is Laura Levy, who's a professor of microbiology and the vice president for research at Tulane. And it's her responsibility to oversee the ethics and the conduct of biomedical research at Tulane University. She gained her PhD from the University of Irvine and has been at Tulane since 1984. To her right is Bruce Greenstein, who is the Secretary of Health for I said the Commonwealth, no, not the Commonwealth, for the state of Louisiana, and has been with us since 2010 and oversees the Department of Health and Human Services for the state with a budget of $8 billion. But Bruce has had a remarkable career. He has alternated working in the public sector for public good and then working in the private sector, particularly in high technology. And he's confronted challenges in healthcare, both in the United States and globally for the last 20 years, and is an individual who comes out of the world of economics. But he has played many, many important roles, both in the federal government and in industry. Currently, Louisiana is going through a major reform of its public health system under the leadership of Bruce, and he has his hands tied, to be quite blunt about it. He is working very hard around the clock. So to have him here in New Orleans today, to be part of this panel and to share his thoughts is truly a privilege. Bruce, we thank you very much. So without further ado, I'm going to ask Dr. Bischoff to come to the podium and to say a few words about the exhibit.
Well, thank you, Dr. Sachs. Good evening, ladies and gentlemen. Thanks for coming to the World War II Museum. It's a pleasure to be on a panel with such distinguished colleagues from the Tulane Medical Center. And I thought what I'd do is just say a few words, sort of framing the issues in a way. The issue is very well framed in the exhibit already, but this is just a reminder of what was going on during this era. And I think the main point to be made is that this movement of racial hygiene was a movement that was going on in German medicine and the biological professions for a long time before Hitler came to power. And not only in Germany, but in the United States too. So when Hitler came to power in January of 1933, this gave then the medical profession a great opportunity to sort of act on what they've been thinking and writing about for a long period of time, namely to create a racially pure body, a Volkskörper that was pure, to get rid of the degenerate people which should not be part of this body of people. In July 1933, at the time, the same day when Hitler forbade the political parties in Germany, the Nazis passed a law for the prevention of genetically deceased offspring, or the sterilization law. And this law then was very quickly put into effect. Just to give you a few numbers, already in 1934, some 84,000 people through doctor's commission, had applications to a special court to be sterilized, of which then 64,500 sterilizations were made. An incredible number of 400,000 sterilizations were made during the time of Nazi Germany. However, we also should not forget that, in fact, the model for sterilizations was this country, was the United States. 29 states in the Union had passed sterilization laws. By the time the Nazis came to power, the first state was Indiana already in 1907. By the end of the 1920s, 15,000 people were sterilized in this country. By the end of the 1930s, 30,000. So these are pretty big numbers. And the Nazis indeed looked to the United States as a model for policies of sterilization, but also to an American immigration law as a model. And this sort of was just the beginning of creating this pure body of Aryan people. Then there was progress towards, from sterilization towards euthanasia. Euthanasia was practiced in Hitler's Germany from 39 to 41, and really beyond that. It was a highly secret program and was stopped when the Bishop of Münster, Cardinal Galen, publicly protested against the euthanasia practiced by the Nazis. How many people were killed through euthanasia? An incredible 70,000 people in these 2 years in six euthanasia centers that essentially gassed people. And one of the amazing stories about German euthanasia is that the people who gained expertise in gassing a huge number of Germans, don't forget these were Germans and Austrians, their own people. These were what they called at the time feeble-minded people. These were people from psychiatric clinics. This was going on all over Germany until the public protests came. So about 70,000. And a story that has just come to my attention this weekend when I attended the German Studies Association meeting in Milwaukee was the paper of a young Stanford historian, Edith Schaeffer. And you'd be surprised what this paper tells us, something we didn't know. You can't find it on Wikipedia yet. Dr. Hans Asperger, the famous Viennese physician who was the first one to diagnose autism. And of course, Asperger's disease today, one autism condition is named after him. In fact, was involved in this autism program, in this euthanasia program in Vienna too. He was not a Nazi party member, but he was a leading doctor in child psychiatry. In Vienna in the 1930s, and like so many doctors got infatuated with Nazism, what they tried to do. And he essentially was involved in a commission that sent what today we would say autistic children to the Spiegelgrund Sanitarium, which was in Vienna and was involved during the war to kill 800 children. So Dr. Asperger, this historian thinks, was at least involved in sending 35 children, probably more, some of whom she can now trace, into the euthanasia program in Austria. Of course, there was a selection process going on, and that's essentially what the people who worked in the killing centers learned. A finer method of selection, and of course then these methods were later on applied to the Jewish population. So you really need to understand this progression from sterilization to euthanasia to the final solution going on in the course of the war. And I think in a way it was a natural progression, and of course doctors were involved at every stage of the game. So I think we should be reminded of that progression. We should be reminded that the medical profession participated in this, and I think it's going to be interesting to listen to the speakers, what kind of meaning this will have for our world today. Thank you.
Well, good evening. I too would like to thank the organizers, and also for giving me the chance, and my wife as well, to tour the exhibit and learn a lot. I think one of the first things that struck me is when I went in as reading the 10 Commandments. And I don't know if you've seen those 10 Commandments in the exhibit, but one of them says, make sure to ask about the ancestry of your spouse before you get married. So my wife, of course, facetiously said, you know, I forgot to ask that question. So I said, well, okay, well, you're stuck now. Well, two things really struck me. Two words, really: eugenics and pediatric euthanasia, looking at the exhibit. Now, with eugenics, they meant the use of reproductive selective technology to purify the human race. I mean, it's really huge. And by that, you know, I do genetic research. I know what it means to look at genetic selection. And we now know, for example, that you could take a blood sample and do whole genome sequencing, i.e. you could see every single genetic base pair that you have in your genome, what it's made for. And then you could look at all the genetic variability and the polymorphisms that could predispose you to disease. So can you imagine if that technology was available 50, 60 years ago to the people who were doing these horrible crimes? You know, they were selecting based on phenotypic features. So they look at you and you don't look right, or if they do a mental test and you don't pass it, okay, so you're deemed not fit. Whereas now you could do gene testing to look at whether you have mutations or you have a predisposition to certain diseases. And there is a lot of ethical talk and discussions about what do we do with this information. in the future. So while I was visiting the exhibit, I was thinking, you know what, we have tools right now that we have to be very, very careful. And as a pediatrician, as an educator for our medical students, I have a responsibility to convey a very clear message that we're here to treat. We're not gods. We cannot do things like others have done in the past. And the other thing, the second topic, is the pediatric euthanasia. Euthanasia is merciful death. But and if you're doing research, you are familiar with that term. But to sacrifice children because they have mental diseases, because they're not fit, because they have polio, because they have rickets, that is, so it struck me. It really is an amazing exhibit. So I just wanted to share with you some of these feelings that I had. And in fact, I'm going to encourage all the faculty to come to the exhibit. I think it is extremely important that they see the impact and particularly try to compare what has happened in the past with the tools that we have right now. And we have to keep our ethics in place. Well, with that, I close, and thank you.
Thank you, Dr. Sachs, and thank you to the World War II Museum for having us and for hosting the exhibit. It was, for those of you who have had a chance to see it, it's disturbing and it's very sobering. I'm trained as a physician, but also as a public health professional. And in reading a bit about the ethics of all of this, if you can use that word, and speaking about the atrocities, but also the ethics of public health and medicine, it strikes me that it is a slippery slope that seems to have been easily fallen down at the time of the atrocities related to eugenics, related to mass sterilization, and then eventually to mass killings. And it is reflecting upon the exhibit, but also reflecting upon my own career. One of the moves that I have made is from focusing on individuals and my responsibility to the patient in front of me, albeit occasionally having to ration at the bedside and make decisions based upon available resources, moving into a role of public health that is essentially what you're asked to do every day. It is the fundamental defining feature of public health, which is that I actually have the legal authority to make choices for society over individual. And the very basis of public health is sometimes grounded upon the notion that it is better to quarantine some for the benefit of the greater good. And as our modern scourges have evolved from communicable disease, though they still threaten us, into those that are more related to chronic disease and personal lifestyle choices, we are beginning in some areas to make grander choices about restricting public access or societal access to things like sugar-sweetened beverages, certain types of food, smoking, that interfere with some people's personal choices. I do not mean to equate full-calorie beverages with the atrocities outlined, undertaken, including even in this nation historically, but I think it's an important lesson for me to remember as a public health official and as someone who trains that it's always critical to balance the greater good with the individual and consider your own potential bias as you're looking at the public. I might just add a couple of other issues. So one is that the responsibility that Bruce and I have is to the public's health, and he and I have spoken about this a lot as we've shared similar roles in a state. And in public health, the way that I have seen it evolve is moved originally from being a great savior, in this country at least, of people. It expanded life expectancy with measures that changed the conditions in the tenements of New York City and reduced rates of tuberculosis transmission and mortality from tuberculosis as one example of many. And over the course of time, for reasons that have been typically described in the literature as the advances in medicine, I'll use one in particular, let's say penicillin for the treatment of infectious disease, life expectancy was dramatically altered by individual level treatments by medical care. And the power shifted palpably over the course of the last century, where public health no longer had a dominant place at the table, and medicine became the dominant player. It's evident in the way that we fund health, the greater good of health for this community. The ratio is about 97% of funding goes to health care and about 3% to public health. Public health also moved into a place of taking care of marginalized populations, the very poor, the uninsured, those that are HIV positive, those that are homeless. And in understanding that a chasm that developed between those two fields interested both in the same positive outcome for people's health, what had been missing for me in my reading of the literature, frankly, is this understanding that public health actually did some really bad things. And one of the reasons that it was marginalized probably was less about just the advances in medicine, but also because of events like what the U.S. Public Health Service did in Tuskegee, which I know Laura's going to speak more about. And so, you know, as I think about the responsibility of my profession, my role as a public health practitioner, I think I also have to recognize that there is a wounded history that has frankly evil in it, and that it explains a great deal for me as a physician and the kinds of responses that we often get from individuals who are dependent upon public health or the kinds of public health services because of a real and palpable and tangible time in our history in this country and internationally when we took advantage of that responsibility and used it for what was actually an evil as opposed to a greater good. Thank you.
Thank you to Dr. Sachs and to the museum for inviting me to participate tonight. I'm glad for the chance. So, as the senior research officer at Tulane University, among my responsibilities is to ensure compliance with federal law when we at Tulane perform research that involves human subjects. So there is quite a tight federal law governing the use of human subjects in research. In fact, many people would say it's too tightly regulated. And I'll tell you a little bit about that federal law, but it's a little easier to understand, I think, in the context of where it came from. Certainly, starting with the Nuremberg War Crimes Tribunal in 1946, where a number of the Nazi physicians were indicted, they were convicted and sentenced. So it's clear then, after the Nuremberg Tribunal, we can correctly refer to the Nazi medical experimentation as a war crime. These were war crimes. They were found, determined to be so in an international court of law. And after the Nuremberg Tribunal, a set of 10 directives was articulated called the Nuremberg Code in 1947. I'm not going to tell you about all 10, but I want to mention some of them to you. This is so important. The Nuremberg Code was the first international standard to guide the use of humans as subjects of research. So some of the 10, really absolutely transformative concepts. The voluntary consent of the human subject is absolutely essential. That's the first precept of the Nuremberg Code. Participation in the research must be voluntary. The experiment should yield fruitful results for the good of society. Clearly, they're thinking of the Nazi war crimes in this case. It can't just be torture. So another one must avoid all unnecessary physical and mental suffering and injury. Really transformative concepts. How about this one? The human subject of research must be at liberty to bring the experiment to an end. The subject, the human subject, must be able to quit whenever they wish to for any reason. We see that one in our current federal law. So, despite these efforts and all our knowledge about the Nazi medical war crimes, we still have a lot of tragic stories some of which Karen alluded to in her remarks, we have a lot of tragic stories in the history of human subjects research in the United States. Despite having witnessed and knowing about the Nuremberg medical war crimes. So, for example, the Syphilis Study at Tuskegee from 40 years from 1932 to 1972. It involved approximately 600 African American men, 400 with syphilis and 200 controls. They were recruited without their consent. They were led to believe they were receiving special, quote, special free treatment. They were misled, in other words, when in fact they were the subjects of research to study the natural progression of syphilis. What happens if we just leave these people untreated? That was the subject of the study. So it started in 1932. By 1946, it was already clear from the data that the death rate was much higher among those with syphilis than among the controls. Nonetheless, the study continued. These individuals were not treated with antibiotics even when they became available in the 1940s, even when they were the standard treatment for syphilis. And when accounts of this study appeared in the national press in 1972, it evoked a public outrage. You could hear from the tone of Karen DeSalvo's remarks that that outrage remains among public health experts. And the outcome of this was a federal law called the National Research Act of 1974, which provided for human subjects protection. One of the things it did was create a body we still have called the Institutional Review Board, called the IRB. The Institutional Review Board is a panel of experts who must review every proposed experiment that involves human subjects before it can be performed. They must review it for compliance with federal law, a whole variety of parameters. This federal law, the Human Research Act of 1974, also established a national commission for the protection of human subjects, and they issued a very important report, a precursor to our present law, which is called the Belmont Report. The Belmont Report articulated 3 principles to which we still adhere in the use of human subjects in research. First is called respect for persons. Respect for persons. You can see even from, before I even tell you what that means, the tone of that language is the antithesis of the Nazi medical war crimes, even of the Tuskegee study. Respect for persons. Participation must be voluntary. Informed consent is required, and coercion or undue influence is prohibited. It is unethical. That's principle number 1. Principle number 2, beneficence. Harm to the subjects must be minimized, and benefit must be maximized. That's principle number 2. Principle number 3 is an interesting one, I think. Principle number 3 is called justice. It says that the selection of the subjects for a study must be fair and equitable. So that suggests, for example, it's unethical to do a study that takes advantage of poor, uneducated African American men with syphilis, that it's unethical to perform a study on concentration camp prisoners who are starving and dying and have no options. The selection of the protection of vulnerable populations is the key here. We've expanded that concept currently under current federal law because there are many vulnerable populations that need protection. Children need protection in human research. Prisoners need protection, and they are protected by federal law. When prisoners are used in human research, they are protected by federal law. They are a vulnerable population, and that's because their freedom is restricted and they might otherwise feel coerced to participate. And so there are special protections to prevent that under the law. We now have a presidential commission for the study of bioethical issues. This commission was created by President Obama in November of 2009. Its goal is to promote policies and practices that ensure ethically responsible conduct in scientific research. It's composed of national leaders in medicine, science, ethics, religion, law, engineering. And their first task assigned by President Obama was to investigate the recent revelations of yet another U.S. Public Health Service tragedy, and that is a study conducted in Guatemala. U.S. Public Health Service in Guatemala between 1946 and 1948 purposefully infected 5,500 individuals with various sexually transmitted diseases. Did so without their consent, without their informed consent. And they also took advantage of vulnerable populations. The study subjects included prisoners, sex workers, children in orphanages, mental hospital patients, all vulnerable populations who need the protection of the law, and this was done without their consent. So that study by the Presidential Commission was completed. It was published in October 2011. It's available should you wish to see it. It's called Ethically Impossible: Sexually Transmitted Disease Research in Guatemala. This is a really complicated issue that remains unresolved. A lawsuit has been filed. We'll see what happens there. Reparations may have to be paid before we're done. We'll see. Unresolved. So finally, I told you that the use of human subjects in research is tightly regulated now by U.S. law. It's in the Code of Federal Regulations, Title 45, Public Welfare, Part 46, Protection of Human Subjects. So it provides for the Institutional Review Board at every institution where research is performed. It requires informed consent. It has terms in the law like voluntary participation, no coercion, evidence of comprehension. The subjects must understand what it is they're doing, and the protection of vulnerable populations. And I'll stop there.
Thanks so much. Good evening. Okay. It's this is really a special event, and I want to start out by saying thank you, first of all, to Dr. Sachs for the invitation, but thank you to this facility. The World War II Museum is such an incredible gem in our city here, and I didn't visit it until about 2 months ago. It was for the first time, and I was just really in awe by what this facility has to offer in terms of education and a good reminder about what we have to be so proud about. And it's really a very fitting place to have this discussion. These remarks are our reaction to seeing the exhibit. And it's easy for us to drop straight into what our specialties are, physicians and research and so forth. But you can't help but miss that first overwhelming set of emotions, just absolute shock, sadness that human beings are capable of such grotesque behavior. In the middle of Europe, in the middle of the 20th century, this was going on. You'd think that maybe this is something that the human condition has outgrown some thousands of years ago of such barbaric acts. I want to talk about three things. I want to talk about the role of institutions. I want to talk about how sadly history tends to repeat itself. And then I want to talk a little bit about the need for vigilance into the future. Now, of course, going last on any panel always has the risks, and they've played out tonight, that all the clever angles on addressing something have been taken. And the remarks really set up for such a great discussion, which we're about to launch into Q&A afterwards. But I want to go over a couple pieces. The role of the institution. What the exhibit shows is that this is the work of tightly coordinated, funded, and executed government policy. This was not a set of rogue doctors that were operating under some special code with the interest of doing their own research and sharing it among themselves. This was government-sanctioned policy that was being carried out. This is where the ethics of individuals and their professions bent over in the most dramatic ways, in ways that we couldn't ever imagine today. But we know that the way that institutions have carried out different types of healthcare over, let's just take the last 100 years, has often led to poor outcomes or inhumane ways of caring for people. In our country here, until just a few decades ago, we would not think twice about warehousing people with mental illnesses or developmental disabilities in conditions that we would look at today as despicable. And in fact, we happen to be living in a state that still has among the highest per capita institutions and institutionalized beds to care for people with mental health and developmental disabilities, while most of the rest of the country has closed down institutions like that and cares for people in their homes and in communities. Everywhere we look, we see opportunities to fight what seems like, as we look back in history, unjustness or bad behavior, things that would be categorized today as war crimes. But we have to look freshly every day at the institutions that we all participate in to make sure with our own ethical screen that we're making the best decisions for our fellow citizens, humans. Just even in the last, take 20 years, it seems like the human condition has not learned very well about what kind of damage we can inflict upon one another, whether it's in eugenics or in, say, ethnic cleansing. Right back in Europe, not long ago, in Bosnia, we were doing, and again, not in a precise way with medical instruments, but with hatchets and with guns. We were watching on CNN on a daily basis 2 ethnicities kill one another. You would think that it has a lot of overtones for what we saw. We watched more recently Hutus and Tutsis in Africa destroy each other in the most horrific ways with the most fantastic numbers, hundreds of thousands. And this is happening in our day and age, not long ago. The lessons that we learned and what was codified in Nuremberg seems to not be able to impact maybe the less, say, sophisticated governmental structures. When governments break down into war, what is perfectly logical institutional review board rules completely go out the window. And so we have to maintain, I think, as Americans that support our government, the pressure that we are able to place around the world to try to avoid things like this happening again. And trust me, in the last 2 years, we're watching some kind of scary and similar activities happening across the Middle East. And we've remained pretty much arm's length, save for some funding for activities. This is an area that begs some very deep ethical questions to us and to our national leaders every day. And there's no easy answers to that. Lastly, I think about the need for vigilance. So I'm not a physician, and I'm not making these one-on-one decisions in my practice. But rather, in my practice, it's a very macro-level policy design that impacts, hopefully, all of us in our state as we try to make our health system better. But I worry about what are great advances that can be misused in the future. The human genome is mapped. Unbelievable step forward in science. That unlocks almost limitless possibilities for a great deal of discrimination. Our laws are not moving nearly fast enough to keep up with the science behind this. We know that in order to identify illness and disease, and that which is potential in the future, now that we can see into the future with genetic mapping, pharmaceutical and other medical treatments are being designed very specifically for the types of disease that we're seeing. And they often will vary by race or by ethnicity. This opens up quite a potential conundrum for those that make policy regarding how that data is used and to treat. At the same time, we're making great advances in health information technology. The great cataloging of the human condition and all of the maladies associated with people's health. We do a pretty good job of keeping privacy and the security of data. And even today, our notion for increased level of privacy gets in the way of us treating individuals as a whole, because we have to separate out mental health information from physical health information. And we know they could be used better together, but we're too nervous about putting them together. Add the sophistication of health information technology and all the data being collected with mapping, and we have potential for very serious problems in the future. Lastly, as we develop all these technological abilities and science-based abilities to see into the future for individuals' health conditions, we're also moving down a track where we ask people to pay a little bit more if they want to engage in risky behavior, say like smoking, or maybe not enjoy discounts in their health care or health insurance premium if they're overweight and they don't exercise, if they don't eat enough vegetables, let's say. Bring the three of those elements together, and again, as a society and as a policymaker with regard to public health, I feel the pressure every day to remain vigilant in assuring that we don't create opportunities for discrimination based on what we now will know about individuals in the future. And if you think about what we saw in the exhibit, with the absolute loss of morals of people that participated in these grotesque crimes, if they had the tools of technology that we have today, we could have seen far more horrific and more precise ways of madness that we observe from the exhibit today. We have to assure, as a society, as humans living together, that we'll never, ever have any little bit of tolerance for anything like that in the future. So, thank you.
What I'd now like to do is to open for questions. If I could ask you to keep your questions short and concise, that would be great. And please introduce yourself when you ask the question. Who would like to start? Please.
I wonder if anyone on the panel has ever seen a 1-hour film called Conspiracy. And it's the Walter C. meeting, and it is where the final solution was achieved. And it's very, very well done, and I really highly recommend it, because it shows how just subtle pressure in kind of a mob mentality can really affect an outcome, whereas a person would not normally give, would be ethical by themselves. Within a group, you get this sort of mob mentality that evolves, and you lose that perspective.
Can you say the name again?
Conspiracy. I would respond by saying one of the points that I took away from the exhibit was the slippery slope that really started soon after the First World War, when Germany lost the war, a lot of introspection about where the country was going, and then purity of the German people, and eugenics and selecting your mate, and then a slippery slope. So I agree that there was a final solution and a decision, and how the decision was arrived at, but really it was that slippery slope beforehand that I took away from the exhibit that is really the warning sign. But I'd like to ask members of the panel, there's a microphone in front of you. Does anybody want to add anything?
Well, I mean, Wannsee is the moment where the final solution is concluded, but we need to understand indeed the progress that goes towards Wannsee, meaning I think already 2 million Jews had been killed on the Eastern Front before Wannsee, meaning the Holocaust was already beginning to unfold as Hitler attacked the Soviet Union, before that Poland, where of course he found the majority of European Jews. So in a way, Wannsee is an important meeting, but it's not really seen as a decisive turning point anymore towards the Holocaust. Only that these bunch of Nazis, including Heydrich, got together and sort of said, now let's do it, but they've been doing it already.
I got the feeling, though, that it was an issue of they needed to go more quickly to achieve their final solution, and this is why Wannsee is so important.
Mm-hmm. Please.
I think we better not forget most of this eugenics originally started in England, probably Stockton originally in the early 1800s. And it was kind of spreading all through European and American society as the great way of treating the human race. So we started the slippery slope much earlier.
I agree with that, and it appears that it didn't end very abruptly. I mean, if you look at American history that she was describing and look at sterilization laws in this country into the 1970s, you can find unfortunate examples that we were continuing to try to make choices for others about their own reproduction. The small comment I would make is about the slippery slope of dehumanizing people. And I don't want to terrify anyone, but it happens in medical school. It happened to all of us that you have to begin to step back as your skin in the back is the first day of anatomy. It's the first day of medical school, and just being able to manipulate a human body first, and then surgically later, and then deal with death and dying. We have to be able to build walls. I think what the modern medical education does very well, I believe that I experienced that in other people, is really prevent us from so dehumanizing those that we care for. A variety of ways, introducing the clinical opportunity early in the career, making certain that we're talking about it, that we have special courses to remind us that we're taking care of people and they're not just objects. And now even specifically reminding people about empathy. There was a recent article in the New England Journal of Medicine about sort of refreshing empathy. So I guess what I'm trying to acknowledge is, first of all, I do completely see that this has been a slippery slope. I'm not sure that we're always completely off it, as Bruce is alluding to. But as a medical professional, as a physician, you can see how if you were not attentive to it as an institution and making certain that your trainees were remembering that these are humans and not allowing that to get too far, I can see how the physicians could get into a position like that. I guess I can see. I don't know. It's pretty awful.
Yes.
Do you all have any concerns that there is unethical human research being conducted by doctors anywhere in the world today?
That's all yours are.
I don't know that we can speak for anywhere in the world, honestly.
Well, I know about gene therapies that are being experimented on people in South America, clinics that are set up for profit that are really experimental, and we don't know how much harm they're doing. There are no safety, no guidelines related to that. I visited many newborn intensive care units in developing countries, not unusual for a selection to be made at the time of delivery for which neonates would be allowed to live and which ones will not be, based on their condition of birth. So I think that across the world we see both some of the slippery slope that we've been describing, but also experiencing grossly unethical studies. Please.
I was wondering if any of you all had seen, granted it's fictional, the movie The Constant Gardener, about how that kind of experimentation by pharmaceutical companies masquerading as trying to help people in Africa has caused issues with actually helping those people in public health venues.
The Constant Gardener, the movie, does anybody want to comment? Lauren? Do you want to take the microphone?
Well, the subject of that film is a troubling one. It takes a strong position. It's a partisan view. Would you not agree? The film it takes a partisan view. I can't speak to its accuracy, to the factual basis, but it portrays a pharmaceutical firm as abusing a vulnerable population by testing dangerous drugs on them without regard to their safety. A United States pharmaceutical firm would not be permitted to do that. It's against the law. I think Dr. Sachs said very well a few moments ago that there are places in the world where pharmaceutical firms would be permitted to do that. There is no law to protect vulnerable populations, and it may very well occur.
It's a very good point. It definitely pushes people to think about what may be happening going into their imagination as much as what's really happening out there. In work that I've done with the Gates Foundation and the World Health Organization, so much of the resistance that comes from help is really not around narrow pharmaceuticals. They're broad cultural issues. There's been decades of graft and corruption by administrations across all of Africa. And so what we're seeing really now is, in order to get large populations to work kind of in collaboration with those who are trying to bring about, and I'll just say, instead of saying drugs or pharmaceuticals, sometimes it's just ways to address disease. One of the most effective, and again, it's not a drug, one of the most effective means of controlling for malaria over the last 5 years has been mass mosquito net distribution, but not done with, say, WHO or Gates Foundation people. It has to be those that are trusted locally within the country, within villages. So I couldn't comment specifically on the pharmaceutical pieces, but it seems like as aid organizations understand better how to cut through the national level of government, but often having to make sure that they lubricate the system to allow them to do the work necessary in the communities. The partnering up in the communities have been, so far, what's led to success around Africa.
Other questions, please? Yes, please.
The mapping of the human genome, which is an extraordinary accomplishment, has there been any discussion, perhaps in government agencies, about how best to use that very valuable information to move medicine forward without it becoming something horrific, something that might cause a government to say, oh, this person is carrying this gene, so therefore they should be sterilized and not allowed to reproduce? Have there been any conversations to that effect?
I could say within Louisiana government there has not been, but I'm happy to pass the microphone.
Actually, the New England Journal of Medicine has published several articles in the past several months about this issue. And there are pros and cons for knowing the details of the human genome. For example, it was discovered that breast cancer patients sometimes carry a defective lung cancer gene or ovarian cancer gene that we have drugs for, not a breast cancer specific gene. And that was only discovered because they were able to sequence the entire genome. So there is a benefit to that. There is also a benefit, for example, if someone has a mutation in a gene called MYH88, that individual is going to develop kidney failure at a much higher rate than another person. And the way to handle this is to tell that person, okay, you know that you're at a higher risk, then you have to go on a healthy lifestyle and lower your cholesterol and be very fit and control your blood pressure, etc. The fear is the health insurance industry. Because if they know this information, then they'll classify you immediately as someone non-insurable, okay? And I think under Obamacare, this will not happen. So
we're not into the debate yet. That's in another hour.
Yeah. But what I'm saying here is that so there are pros and cons. There's certainly a huge debate about what to do with the information we're going to get from sequencing the human genome and knowing everything about the risk of each individual. So we don't know that information, but you raise a very good point, and there should be more and more debate, and we should hear about it more.
I mean, the technology is almost getting to a point where you can do the test in a day, get the results in a day, and it costs $1,000 to do the to run your complete human genome. The concept of a pre-existing condition really becomes interesting. All of us have pre-existing conditions, and that will come out as we run our genome. And then the question is, how does the insurance industry deal with that? How do we deal with that in terms of life insurance? So there's some really interesting questions and potential for discrimination, if you like, with the whole genomics area. Anybody else want to talk about the genome project? Okay, please, yes. Well, actually, let me ask somebody who hasn't asked a question. Excuse me.
Brooke Wojtowicz. I'm curious, to what degree do you think that the role of genetic predisposition and personal choices comes into play in what counts as discrimination, or if something is discrimination, how acceptable it is? For example, someone who's predisposed to risk-taking behavior who smokes, or and then suffering from, or not suffering, I guess, but paying higher taxes on cigarettes, or someone who is predisposed to being overweight, who has to pay extra to get the seat extension on an airplane. How do you know what counts as discrimination?
That's a great question. This goes to her.
I think it goes to Bruce and I. I don't know anything about genetics, but I believe that I read recently that they can determine the entire genetic makeup of a newborn, and that can lead to saving of lives immediately. So there are some real benefits to it. That said, you're getting at my points exactly. I think that as we know more about people, about them genetically, about them medically, as we move to a place where we're going to start knowing about your personal lifestyle choices, behavior, your income, where you live, whether you smoke or not, because we're going to be building more and more data about folks, we can use that information to make population-level, evidence-based decisions that can be positive. So, for example, you could use data to look at rates of asthma in children in our community, and you could then map that against rates of smoking in our community in public housing, for example, and make a decision that there are clusters in public housing where we're allowing smoking, and you could determine that you're going to outlaw smoking in public housing so that the children who live there didn't have increased rates of asthma. This is not a made-up idea. This actually has happened on the West Coast. And you really move into a space of interfering with someone's personal liberty if you don't allow them to smoke in their own home. But you could say that it's a public benefit. They live in subsidized housing. Therefore, we have the right as society and government to dictate what people do in their own homes because we're helping to pay for it. I do not have the answer for that. But I'm saying that this is actually happening as we speak. And so the ethics of it, the choices, the trade-offs we make between individual and society are becoming ever more real over time. As we understand about then people's risk for smoking or risk for other sorts of addictive behavior, we can use big hammers like tobacco tax and preventing smoking in restaurants, but really there is an opportunity actually there to get a better pharmaceutical intervention, as an example, to help people ever begin smoking, right? If we can find the right kinds of changes that accompany lifestyle choices, maybe their own lifestyle changes, then we might be able to do a greater good. But you're asking a question that's actually a policy decision happening every day in this country.
If I may add,
sure, please.
Most diseases are not caused by a single gene mutation. They're gene-environment interactions. Okay, so you could be predisposed but never manifest the disease, but not until the environment, appropriate environmental setting, triggers it. So if this information, the genetic information, is available early in life, you could intervene in the environment of the child to prevent that child from becoming a smoker to begin with. So I think there might be a way to use that information in a very, very constructive manner if we are very smart about it.
So let me try and ratchet up the discussion to a very real issue confronting obstetricians today. Roe versus Wade, I don't wish to get into a discussion whether it's you are pro or against abortion or abortion only in limited circumstances, but parents-to-be are offered prenatal diagnostic tests, and the most common is for Down syndrome and then for other prenatal conditions. However, because of the ability to make genetic diagnosis in utero, that if a mother or grandmother of the pregnant woman has a history of breast cancer, there's an increasing number of people who are requesting of obstetricians to test the fetus for risk for breast cancer and to consider then terminating the pregnancy if that is positive. I'm not here to discuss the ethics of whether it's right or wrong, but to give you a real example confronting medicine with the ability to make diagnosis. Now, the breast cancer gene doesn't mean you're going to get breast cancer. And if you're going to get breast cancer, it may not have happened for 20 or 30 years after the delivery of the child, by which time science has advanced. But a woman who has perhaps experienced a mother dying at a young age from breast cancer may be very highly motivated to make sure that her daughter doesn't have that condition. These are some of the real issues confronting modern medicine because of the scientific advances, and people could think that that's a little bit of a slippery slope as we begin to think about some of these issues confronting society. So the whole issue of the Human Genome Project is confronting us with modern examples, and we are going to have to be extremely careful if we're not to find ourselves in some aspects of eugenics or other trying to select populations. Other questions, please.
Related to that, two things. Can it be considered then a good thing that epigenetics has such a large impact on actual disease being expressed through genetics, on the fact that we haven't gotten as far in the ethical debate? And the other one is a little bit of a side on the abortion side, where we're not even using genetics on a daily basis for that. Where in China and India, we're seeing rates of abortions just for girl fetuses on the ethical debate on that side.
Yeah. Somebody want to take?
My research is on epigenetics. So for those of you who are not familiar with the term, epigenetics is the inheritance of information without a change in the DNA sequence. Okay, so the cells are inheriting the same DNA, but they're expressing different phenotype. And it's because of the environment in which the DNA is living. And if it changes, then the DNA expression of the DNA sequence changes in the end. And this is where I was saying gene-environment interactions is all about epigenetics. So you could have a predisposition based on your DNA sequence, but could you modify it by the environment, by introducing epigenetic changes that tell the gene, no, it's okay, you're not going to get expressed because we've modified the environment in which the DNA is living. So I hope that answers part of your question. So the more we understand about epigenetics, you know, and the NIH right now has a huge epigenetics program that wants to know everything about the epigenetic information that's in the genome. They call the epigenome. Just like they did for the DNA, now they're going to look into the histones. So I believe that we're going to have at the end of the day, we're going to have a genetic code and an epigenetic code, and it's going to be a huge amount of information that we need to decipher, and it'll be interesting.
Please.
My name is Paul Burgoyne, and my question is, in Germany, in 1915, I believe it was, at Ypres, the Germans launched poison gas attacks in contravention of the Hague Declaration. And my question was, what did the German public feel about this use of science against enemies of the state? Did that lay the groundwork for a later acceptance of medical science against enemies of the state, internally, as they call it?
Dr. Bischoff, sounds like a good question for you.
I never have heard those two put together. I mean, you know, gas warfare was practiced in World War I once it became available on a fairly regular level, but they soon found out, you know, that everybody could practice gas warfare, and in that sense, everybody would get hurt on a massive scale. And the amazing thing about gas warfare is that then there was sort of some agreement not to use it again. And it was considered in World War II, but even the Nazis decided not to use it because they knew very quickly, you know, the British and the Americans would come back at them. So I haven't seen gas war sort of related to the issue of racial hygiene, you know, that sort of led down the slippery slope. So I couldn't add to that.
I was just wondering that it is science against used against perceived enemies of the state, if you will. That was my wonder about whether did the German people accept that this was being used, therefore leading them to a later acceptance of other science.
The people usually are not asked about modern technologies that their governments use in order to further their, you know, strategies and you know, war strategies. So I don't think the people were much polled on that, you know.
We're going to take probably one or two, if they're short questions, because I think there are a lot of people who want to be home for the debate tonight. So.
Yeah. Walter Levy, currently we have a lot of economic pressure to deliver health care. We have to decide where we're going to put our resources, our economic resources in the delivery of health care. And that will necessarily create choices of who is going to get health care and who isn't going to get health care. And how do we, in a very ethical way, put our resources to work? We're dealing with that right now. Mr. Greenstein is dealing with that right now in here, and Dr. DeSalvo is dealing with it locally in New Orleans. And we're looking at groups of people who are worried that they're going to be disenfranchised in their health care. And how do we make this moral and ethical decision to take this group of people and say, I'm sorry, you can't get the care you were getting before, and you must find it somewhere else. I don't know how we make this decision.
Who would like to go first?
So, the end of your question, I took it as rhetorical, because when you said, I don't know how we make those decisions, because you actually do. We play it on the front page of the newspaper seemingly every day right now. This is a very interesting question, because we tend to equate the right side of the equation on how we allocate resources to somehow equaling someone's good health. And so I'm going to take a step earlier in the supply chain of health, rather than equating just dollars spent equal either a favored disease or a better place to live in the state where there's more free health care or something to that effect. There was a hearing last week in the legislature around LSU's health system and the redesign. And there was a senator that made he's an incredibly caring senator, and he said, who is going to decide who lives and who dies? And that was the question was like, you know, bait. It said, are you going to say that because I'm cutting here, then whoever is making the cuts is going to die? And it made me think about that, because I took a step back and I think we somehow have divorced ourselves from a responsibility of our own health. So here's a state, 49th in the nation with health outcomes. And we have divorced the notion that an individual carries a responsibility for a great deal of the outcome of their health. So we talked about predisposition to, say, smoking. Well, I think I might have a predisposition to pizza, but I've figured out that I don't eat it all the time and therefore have lost some weight. If you smoke, stop. If you are practicing, say, poor eating habits and not exercising and not taking medications and using the emergency department as your source of primary care far too often, those are things that are not acceptable in an environment where we have limited resources. But we're not somehow able to say that there's an expectation when you use the public health system that we need your help. You need to be a partner in delivering good health. You can't just be somebody who comes in to take health care and then not do anything afterwards. So we think about issues like that all the time. I mean, for public health practitioners, we're always thinking about adherence and behavior change and how do you make those changes stick, and they're very difficult. We've tend to focus our concern about cutting budgets over a number of hospitals, but in fact, just this morning I was with 3 different parish presidents. 2 of them don't have an LSU hospital in their parish, and they think about, wow, it would be great if I had a hospital here that could get cut, but I don't even have a hospital. And so those people don't have the same access as those that live in an area that does have a hospital that provides charity care. So the notion of us kind of making these ethical decisions are so multifactorial, and they're very, very difficult to peel layers away and consider any one decision in isolation. So what we try to do is we take the available resources and we're ruthless with making the best decisions, the most efficient method of delivering that care to squeeze every bit of value out of those dollars available. And listen, it's not been the case for the last 50 years like that, where we've had maybe too much money to force the efficiencies. Now we have no choice. And as a practitioner, as an administrator, I'm tenaciously pursuing the best options that take the dollars that we have and extend the amount of care, the amount of medical training, the amount of value out of it. And that's exactly what we have to do moving forward.
Karen, did you want to say a word?
So my friend Bruce is correct that the determinants of health include personal choices and behaviors. It includes genetics. It includes the environment where we live, learn, work, and play, as Samir has mentioned. It also includes health care, 10 to 20%, depending on the model you believe, of health care, of your health outcomes is health care, which is a very small percent considering I told you earlier we spend the vast majority of our money trying to improve health by inputting into that part of the equation and thinking that we're going to make a major difference on the other end. And so, yes, it is true that the social determinants and lifestyle choices and genetics have altogether a larger impact than healthcare. The reality is that we are spending more per capita on healthcare in this country than any other industrialized nation and getting some of the worst health outcomes. We have in this state rates of death and disease that rival those of developing countries. And so it is indeed embarrassing that we've gotten to this place. I guess, the way that I would see it, though, is we have, even within a zero-sum game, there is opportunity to improve efficiency, but it's sort of like asking someone to lose 100 pounds overnight, which causes them to have to cut off a leg, is not necessarily the way I would get to getting somebody to losing 100 pounds. It would be more systematic and gradual. There is no disagreement between the people, between us up here, I guess I would say, about the place we need to get. It needs to be more efficient because we don't have unlimited resources. Although we've been saying that in healthcare for decades, and we keep coming up with more resources. It's the fastest growing part of our economy, but it really is. It is impairing this country's ability to compete on the international stage. Bottom line, period. Now, what's special about Louisiana and the common good, since we're on that topic, is that we have an economy in this state. So first we have for whatever reason, poor health for all the reasons we mentioned. But on top of that, we have an economy that is a cultural economy, and it's a service industry in which 2/3 of the uninsured in our state are working full-time, but still don't make a living wage and don't work for an employer who offers health insurance coverage. And access to health care in the United States of America requires some form of public or private insurance unless you pay out of pocket. We don't have really other systems. The one system that we did create in Louisiana was a publicly funded public hospital system with some associated clinics, which is on the decline and waning. And so there is this gulf about to emerge where we are making potentially a leap to a place where people have, I hope, a portable insurance product, be it public or private, and that is paid for through some mixture of common good funds with their own hard-earned wages and contributions from their employers, that would allow them to have access to the most efficient place of care, the prevention that were necessary, and a place where they are supported and encouraged and coached to be as healthy as they can be. But that until we can get to that place, I am genuinely concerned, as I've expressed in public, about that gulf and what it means for the rapid decrement in access to care. So yes, everybody's got responsibility, but I also believe that we have responsibility to help those who need that help, give them a hand, not necessarily a handout, but a hand up. I certainly had that when I was growing up. And in this state, until we can rectify our economy and make it into one where small business can afford health insurance products, or we have bigger industry, I think we have to really think about how we use the common dollars to get people to the bridge to the other side.
Now, after that discussion, why would you want to go home and watch a debate? I mean, you know, that would make no sense to me at all. I'm going to take the prerogative. I know there was a gentleman over there had a question. I'm sure the panelists would be happy to answer your question, but I'm going to take the prerogative to wish you good night. Join me, please, in thanking the panelists. Tomorrow in the School of Medicine Auditorium on 1430 Tulane Avenue at noon is Dr. Art Kaplan, probably the world's expert in medical ethics. Extraordinary individual is our keynote speaker. And it's been, as I say again, a real privilege to work with the World War II Museum over the last couple of months with this exhibit and the educational programs that are related to it. Thank you very much indeed for coming out tonight. Thank you.